My name is Mirjam Visser and I'm a PhD student at the University Medical Center in Utrecht. In this presentation, I will present some of the results of an ex vivo validation study of a clinical HIFU system that will be used for clinical histotripsy treatment. At this moment, we are planning a first-in-human phase 1 clinical study that will assess the combination of histotripsy and immune checkpoint inhibition, the iFocus study. The study design of this trial is discussed in another presentation on this focused ultrasound platform. In this presentation, I will focus on the ex vivo validation tests performed on a Sonderleaf V2 MR HIFU system of Profound Medical. We wanted to validate the clinical system for different tissue types and for some different sonication parameters to ensure safe and controlled histotripsy treatment in clinic. This is important as preclinical evidence has shown that lesion formation can vary as a function of tissue type and sonication parameters. We therefore defined two aims for this ex vivo validation study. The primary aim was to assess the accuracy and the efficacy of the clinical system for different powers, depths, and tissue types. The secondary aim was to assess the correlation of histotripsy lesion dimensions on MR imaging and histology, to assess whether MR imaging can be used to monitor histotripsy treatment. This was our experimental setup. We used fresh ex vivo tissue, which was either bovine cardiac muscle or porcine liver or skeletal muscle, which we degassed in phosphate buffer saline. All sonications were performed using the Sonderleaf V2 system. And prior to and immediately after the sonication, T2 star weighted images were obtained to visualize the histotripsy lesion. After sonication, tissue blocks were either assessed using gross pathology or fixed in formaldehyde, embedded, frozen, and sectioned with a cryomacrotome, which can be used to visualize lesions on histology and to assess the 3D dimensions of a histotripsy lesion. The Sonderleaf system allows for real-time temperature monitoring for safety using MR thermometry. On the right upper corner, you find the sonication pattern and size we used. Our treatment cell sizes have a total width of 5 millimeters in diameter, and it exists of an hexagonal pattern. In the right lower corner, you find our most important sonication parameters. This image, the one on the left and the one in the middle, show slices of the cryomacrotome stained with HNE of bovine heart. On these slices, we could clearly identify the hexagonal pattern. On the gross pathology, we did not identify the hexagonal pattern in bovine heart. However, there was clear liquefaction of the tissue. In porcine liver, we did not identify the hexagonal pattern using the cryomacrotome. However, similar to the bovine heart, there was clear liquefaction of the tissue, visible on gross pathology, but also on the cryomacrotome. The spatial accuracy of the system was assessed by comparing the planned treatment location and the location of the maximum temperature measured by MR thermometry. These column scatter graphs display the accuracy for the different treatment parameters. The y-axis shows the difference between the planned treatment location and the center of mass of the temperature in millimeters. On the x-axis of the column scatter graphs, the three different axes of the treatment cell are displayed. Right, left, and feed head are in the plane perpendicular to the propagation direction. Anterior, posterior is in the plane parallel to the propagation direction. We found that the system was less accurate in the plane parallel to the propagation direction. However, in this plane, the accuracy still remained below 6 millimeters, and in the plane perpendicular to the propagation direction, the accuracy was even below 3 millimeters for all different powers, depths, and tissue types. Secondly, we assessed efficacy. We assessed efficacy by assessing the number of treatments that resulted in a lesion on T2 star weighted imaging, a hyper-intense lesion. We identified during the experiments that if we did not see a hyper-intense lesion on T2, that we were not able to find liquefaction of the tissue on gross pathology. The green box in this table indicates that we succeeded in the treatment for more than 2/3 of all treatments for that treatment parameter. A red box indicates that we succeeded in less than 1/3 of the treatments. As you can see, the maximum depth reached in porcine liver and bovine heart was 30 millimeters. A threshold power was apparent of at least 750 watts was needed to create a histotripsy lesion. Sonication in muscle resulted in ablation in all for all treatments. In the right table, the mean lesion dimensions for the different treatment parameters are displayed. We found that the applied power did not substantially influence the lesion dimensions after the above the threshold to create a histotripsy lesion. Lastly, we assessed the correlation between the histology data we acquired using the cryomicrotome and the lesions on T2 star weighted imaging. The left figure shows the segmentation of the cropped cryomicrotome images. In the right table, the differences between the dimensions we found on cryomicrotome and T2 is displayed in millimeters for porcine liver and bovine heart. We found that lesion dimensions on T2 star weighted imaging and histology corresponded closely in all axes. That brings me to my conclusion. In this ex vivo validation, we found that the Sonolith V2 MR HIFU system allowed for spatially accurate histotripsy lesions in ex vivo tissue for different tissue types, at the different powers, and at the different depths. We found a threshold power of 750 watts and found that the efficacy of histotripsy and the creation of histotripsy lesion dependent on the depth, the tissue type, and the power. Lastly, we found that the lesion dimension on T2 star weighted images corresponded closely with the size of the planned treatment cell size of the histotripsy treatment. This data is used to create the investigator medical device dossier for the first in-human study on histotripsy and immune checkpoint inhibition, the iFocus study. I would like to thank the wonderful team at the UMC Utrecht, and especially Roel Dekkers, Clemens Bos, Cyril Ferrer, and Prof. Molen. But also, of course, our other partners, and especially the partners at Profound Medical. Thank you for your attention.